Thank you, Dr. Trautman. We'll now open it up for questions and discussion. So we'll start here.
All right. My name is Marian Grant. I'm a consultant for several national palliative care organizations, CAPC and CTAC, and I wanted to add an additional force to education for broad clinicians, non-specialist clinicians, and that is health insurers and payers. And I'm looking right at Leslie Foran from Cambia, because several of our progressive payers who are promoting community-based palliative care are requiring that the physicians and the clinicians in their network take the CAPC courses, and maybe Bryn can say more about this, take some of the CSU courses, provide CAPC memberships to them so that they can do that. A very ingenious way, I think, of applying pressure. Yes, clinicians are busy. I'm a practicing palliative care nurse practitioner. I am recertifying in both specialties at the moment. I got a lot of CEs I got to take. But I do believe that it gives an additional employment and system impetus that the clinicians who are doing this work, or even the primary care people working for some of these payers, are being encouraged to develop these additional skills. And I don't know, Bryn, if you want to say anything more about your experience with payers.
Yeah, a slide that I had to flip through too quickly in my presentation showed like a comic book style frame, and it was a before and after story of a woman who has dementia, who slips and falls when she's getting up to go to the bathroom in the middle of the night. She's laying on the floor, she's in pain, her husband panics, calls 911, and the last frame in that graphic novel story is the ambulance pulling up in the driveway. So that's story one, scenario one. Scenario two, which learners of our courses see, is that Martha's husband had received education about, well, Martha had been prescribed very low dose liquid morphine, and her husband had been taught when it was appropriate to administer that if she had pain at home. He'd been given education and strategies for calming her anxiety and kind of behavioral symptoms at home, and they'd been set up with a friendly visiting program. So he was looking forward. Yes, she was up in the middle of the night, but he was able to give her medication, helping calm her down, and he was looking forward to a card game the next day with his friends. Last frame of that story, the ambulance doesn't come. So you can see how that story, whether it was training for clinicians in a provider organization or for case managers and medical directors in a health plan, really resonated to anybody in any side of that equation. And so, yes, CAPC, thank you, Marian. CAPC has worked with several health plans to train case managers and medical directors in how best to interact with treating clinicians about whether their patients might, or their members, might need access to specialty palliative care, and case managers on how to assess for suffering that's happening in the home for members. And those implementations have been very successful to date.
Thank you. Other questions or comments?
Yeah, just one quick question for Dr. Holmboe. First of all, thank you from someone who works heavily with graduate medical education learners of all types. There's actually, I think, growing interest across specialties. Folks need some guidance on this. So the leadership that the ACGME is kind of putting forth, I think, may help frame that. I was interested to see a couple of things. One is the core competency framing and the idea that expectations, especially around communication skills, are cross-cutting. And I heard you also mention harmonization work that you're doing across specialties as well. So I'd like to hear you talk a bit more about that, because I think the more we can sort of move to a GME culture that talks about what's common across all practicing clinicians, I think that will help not only our programs integrate and collaborate in ways, and I think raise the bar for things like communication skills, but in the end will lead to a better patient and caregiver experience, because they can expect some consistency regardless of the tribe that their physician's from.
So thank you. I think you did a great job describing exactly what we're trying to accomplish. Yeah, it's been an interesting journey when, just for those who may not be familiar with the 6 general competencies, medicine has 6 general competencies that were put into place in 2001. And it was left to the programs to figure out how to implement them. I was actually an associate program director at the time, and people really struggled. The whole concept around milestones was simply an attempt to turn them into developmental language to help create shared mental models. And so that was just a modest step forward. I think one of the decisions made, was a logical one, was they would leave it to the specialties to kind of decide what made sense for them. And that helped with buy-in for most specialties, to be honest, not all, when we started in 2013, but it became pretty apparent quickly when we did a study of crosswalking the 26 entry specialties, all of their competencies and how they describe them, that when you have 188 different ways to describe professionalism, you've got a problem. When you've got X number of ways to describe communication, and so when we looked at professionalism, communication, practice-based learning, and system-based practice, in total across the 26 different sets we looked at, there were 881 different themes. And so the argument we made to the group as we move into round 2, can we come up with some again, harmonization or consensus around what we think is core to every discipline. You can add other stuff if it's important to you, that's fine, but everybody really needs to attend to these things like patient and family-centered communication. We should all agree that's important, and we should have the same mental model around how to get there. We didn't have a chance to share, and actually James talked about this earlier, there's pretty good research around professional development from people like Anders Ericsson for expertise and the Dreyfus brothers. And one of the critical elements that's necessary to get people to expertise, one is you need to have good coaching and feedback. But the coaches have to have a mental representation of what expertise looks like. And when you have a highly variable representation of expertise, we're all in trouble. And I think that's, to be honest, where we are across all the health professions. We've not taken the time to try to codify and define that, and not taken enough advantage across disciplines, let alone interdisciplinary medicine that you raised. So our goal was to try to not only create harmonization where all specialties would apply essentially 12 core competencies, there's 3 within communication, but that they were developed with an interprofessional process, right? So it wasn't just physicians sitting around, but we had public members on those groups, nursing, other members of the healthcare team, particularly communication professionals, because they're critical to reconceptualizing. So our hope is what you just nicely described, that we can now share resources across the specialties, that will have a shared mental model, so no matter what service you're on, these are the expectations. I don't care if you're on an ortho service, to an oncology service, to a general medicine service, you should expect this from the communication side. And we need to train people up to be able to do that. It's also enabling us to be able to make some resources available across all specialties in ways we couldn't do before. So that's our hope. And in tapping into the good work, I can tell you that's been done by the hospice and palliative medicine community has been amazing. You've been trailblazers. You've been on the front edge. You were one of the first to create the harmonized milestone set. That's been huge. That group's been amazing, and they've influenced others. So I'm hopeful. The good news is I didn't know what kind of pushback we would get. We didn't. So almost every work group, Milestone 2.0 work group, and it's over 50 now, have said, yeah, these look pretty good. We're going to go with these. And we'll make adjustments for context, but we're not going to mess with the core constructs that we think these are important. So stay tuned.
Thank you. I'll remind you, for the sake of our colleagues online and the recording, please identify yourself and your organization as you ask your question.
I'm Amy Berman from the John A. Hartford Foundation, a nurse by training, and thank you for an outstanding panel. When I think about the care in the clinical environment, first I have to commend you for the role all of you have played in advancing work around communications. There are soft skills. There are also hard skills. And I also appreciated your comments specifically that we don't tend to see demonstration of many of these skills. You know, we see them around procedures, but not around this kind of care. My question is about the role of the clinical site. We have people who are being trained after or educated. Nursing uses education versus training. We think about the experiences that they are getting, oftentimes in places that are poorly prepared. Things like a lack of referring to palliative care in cases where clearly palliative care should be engaged. So what is the role that ACGME will play in advancing the clinical sites or pushing the academic institutions to prepare their clinical sites and expect them to be a good clinical site in preparing our workforce?
I am so glad you asked that question. This is something that's become really important to us. Two things. One, we actually have as part of the accreditation system something called CLEAR, which stands for the Clinical Learning Environment Review. And it's all about site visitors going on site to learn how they're incorporating residents and fellows into institutional practices across a range of activities from quality, patient safety, professionalism, attending to wellness, et cetera. That whole part of our program is focused on the C-suite at the institution to get them to understand they got a bunch of learners running around who are providing a majority of the frontline care, and they have to attend to how they're incorporating that into the institutional practices. That's number one. The second, and this is research, I've been involved in a little bit of it, and there's a growing body of research, is recognizing that the performance at the level of the institution has an impact on how people turn out. In medicine, there are now over 10 studies that show an association between the quality of care delivered at the institution and the quality of care provided by the graduates of that institution. And it's pretty sobering. It appears in some of the studies, one by David Ash and his colleagues at Penn, and then Candace Chen, who did some work around cost, that impact appears to last for at least 15 to 19 years. So what happens in Vegas doesn't stay in Vegas. And I think that is really important. So we can no longer just say, like, hey, I'm going to give you this curriculum and we're going to throw you out there and we hope you're okay. If you're not going out in the front lines experiencing it, and if the institution is not enabling really high quality care, then you're absolutely right. People will come out insufficiently prepared, despite whatever abilities or capabilities they may have. And so I think we have under-recognized the profound impact of the environment, the institutional practices, and the skill sets of the institution. There's lots of data that shows this imprinting. We've known for years in radiology, for example, that if you work with a less skilled radiologist as a trainee, what do you think happens? You're less skilled. So we have to, and I think this, again, is cross-cutting across all health professions. We're going to have to attend to more of that. So thank you for the question.
Thank you. Over here.
Good morning. My name is Leslie Foran, and I'm from Cambia Health Solutions. And thank you, Marion, for the shout out. From our perspective of our regional health plans, we are piloting, we have been using the LNIC training for our internal case managers as well as the CAPC online. And that's been really great for our case manager, nurses, and social workers who are doing telephonic work and that they don't have capacity to go to on-site trainings. And so we're grateful for that. We have gotten great feedback internally within the health plans. And this year we have taken it a step further to build out our provider network. And that was a big challenge for us. We heard the need that the providers needed the training. They were coming to us with that, but we didn't know how to build that. And so this year we've started piloting with CAPC about recommended modules that the providers can take. And then next year in 2020, we'll be tying that to quality incentive and advanced care planning. So from a healthcare perspective, we really see this as a partnership in training and building out our robust network of providers. So we're grateful and we look forward to continuing our partnership next year with CAPC on that.
And you are an example that we hope all other plans follow.
And if I could just add to that, I think within nursing, everything that we do with faculty in schools of nursing, we try to really emphasize bring your clinical partner with you. You know, bring someone from the clinical setting where your students are being taught. And also an interesting thing, so the work, as Deb described, we just launched with the schools of nursing 3 years ago, and we have over 300 nursing schools. We just launched 2 months ago the graduate education. But I want to just again emphasize the importance of the foundation support. With the Cambia Foundation support, we've been able to create both of these curriculum, undergraduate and graduate, that have gotten us into 300 schools of nursing and growing. And I want to also just say, this does not have to be so incredibly complicated or expensive. Because of the Cambia support, the cost per nursing student for the entire LNET curriculum is $29 per student. $29 a student gives a student a full year access to all 6 modules. And talk about, what you're sharing from ACGME, the impact of that one nurse will have for an entire career ahead. I mean, $29 is a pretty good investment. So, but we can only do that with the support of foundations, support of institutions, to say that this is important.
Dr. Meyer?
I'm sure it's obvious to everyone who's here. I just want to call out the brilliant strategic wisdom of Betty Farrell and AACN, and medicine has a lot to learn from the way you have approached embedding this content into undergraduate and graduate medical education through partnership and collaboration. So we'll be calling you for advice.
Do we have any other questions or discussion? If not, we have about 2 minutes left. I'll give any of our panelists, if you have a final word or anything you want to add. Otherwise, we will move into our next session, which is lunch.